And one of the ways you can tease that trick out is to use this idea of twinkling. So Doppler flow, the physics behind it are all about frequency change. The beam sends out a impulse on a given frequency. It tells you when it receives a impulse back and translate that time into distance on the screen. But it also analyzes the frequency of that returning echo. And if it is higher or lower, the machine can tell you, well, usually that means that I hit a moving target and there was additive or subtractive velocity to my beam speed. So I think that thing was coming towards my beam because it came back at a higher frequency than I sent it out, or it came back at a lower frequency, so I think the thing was moving away. And sometimes, just like in grayscale artifacts, there are Doppler artifacts also. So there aren't really any giant vessels right here behind the bladder. Certainly not enough to produce this kind of multi-directional high velocity flow. Like this isn't like an artery pulsing. This is the two opposite ends of the blue and red Doppler spectrum showing very high velocity signal. So that's what a stone will do. If it's covered in a bunch of little bubbles and you put Doppler on it. For ultrasound physics reasons that are beyond me, it produces this artifact called twinkling, which is what's shown here. Multi-directional, high-velocity appearing Doppler artifact. Right at the area where you get the ureters bulging into the bladder. So this is indirect evidence that there's a stone sitting here.
Why would you say something with the gulls?
You can sometimes. Yeah, it's just people generally don't need it as much because they're sitting in this big bag. You just see it. So transverse cut. What's this? I think that's rectum. Empty rectum.
Yeah,
this is like the mucosal, yeah. And then here's the stripe within a flat uterus above. And here's a unilateral bladder bulge with twinkling. So transverse cut, bladder's empty, uterus lying above it. So we've got the gain cranked up a lot, right? You've got all this flash artifact. Sometimes you need to do that to tease out the multi-directional twinkling flow behind that structure there. Now that structure, you can see this hyperechoic white thing. You probably didn't need the twinkling, but we put it on to be like, and look, also twinkling. And then sometimes people will put flow on the kidney just to help them with that sense of like, there is a vascular inflow to the kidney that looks hypoechoic. And often at the beginning of scanning kidneys, you'll be like, is that hydro or is that vascular inflow? So you can always throw Doppler on to try to differentiate what dark structures are vascular and what are not, what are collecting systems. So this is mild hydro, but any dark structures you were seeing around in other places that fill with flow are vascular. And what's this demonstrating? Yeah, bladder jet. So your urine does not drop into your bladder. There is a layer of smooth muscle surrounding the ureters. It's very small, but it's there, and it peristalses. It peristalses pretty regularly, every minute, every 2 minutes. It does a little squeeze, and that causes your urine to emerge into your bladder as a jet. In kids, you often don't even need to have a Doppler flow box on. You'll sometimes just be scanning a bladder, and you'll see this little hyperechoic, like, pew, go in, which is just a difference in the specific gravity between the urine that's in the bladder and the urine that's coming out. So there's a density difference, so you can actually see that. But you can also put a Doppler flow box on and just kind of watch at the back, and you will see pew on one side, and then you wait pew from the other. But it will take a while. It'll take sometimes 2 minutes to see a jet. And this comes back to why renal colic pain is colicky pain instead of constant. So you're blocked, your kidney capsule is distending, that hurts a lot. And then the tube going down to your blockage tries to squeeze, right? Tries to peristalse. It can't. Oh, this back pressure comes up and causes pain. And there's some people who theorize that like the way in which NSAIDs and ketorolac help with renal colic isn't even from a pain perspective, it's from a COX-2 inhibition of smooth muscle contracture. So just a little video clip of what jets look like in real time. You can tell which one it's coming out of from the directionality of it. I'm going to steal some of Greg's slides, because now that we know these different things to scan, you got to kind of analyze, well, what's really useful, what's not. There's certainly a large volume of really good evidence supporting the use of ultrasound as the first approach to looking at the kidney stones. That hydro seen on an ultrasound in the right clinical context, which is usually like a patient you don't think could have cancer. You go practice in adult medicine. This makes a lot of sense, right? Yeah, ultrasound first, and then if you're still confused, move on. Maybe combine an ultrasound with an X-ray. That must have good performance characteristics, and it does. That has really great performance characteristics. And it is far from being the dominant practice in adult medicine. Acute flank pain, CT, like crazy. Good New England Journal article a couple years ago comparing if you did CT first to POCUS first for outcome measurements, like not just for accuracy, but for what about if you take those two approaches and then say, well, what's going to happen to you downstream in like a month or two? Is that going to change who needs an intervention or not? Those two pathways were equivalent. So you can actually make the argument off of really good literature that just doing POCUS, not even radiology ultrasound, is equivalent in terms of management to the gold standard of CT. And then people often come back to this idea of jets, because everything that we do in ultrasound, we want it to make sense, and we want it to change patient management, and we want it to all fit together nicely, and sometimes it doesn't. So people you'll hear urologists do this, you'll hear radiologists do this, you'll hear your point of care colleagues do this. They'll say, well, there's hydro on this side, but there's a jet, so I don't think they're going to need intervention. Or there's hydro on this side, but there's no jet, so don't let them go home. They need that stone removed. They are completely obstructed. But when you dive into the literature about jets and their utility and whether they can actually guide you in those things, you find it's not very good. This is just one example that comes from the point-of-care ultrasound literature that says hydronephrosis is useful. You can have a stone that's not obstructive, and no hydronephrosis, and you won't need to be admitted. But that loss of an ipsilateral jet doesn't actually correlate with whether patients come in or not. And I've had patients with stones and no jets who achieved pain control in the ED, went home, and on my follow-up, they came back to urology 3 weeks later, and their hydro had resolved, and they don't remember passing a stone. So know about what a jet is. It's kind of cool to know how to do it. I don't really do it anymore because I don't want to sit there for 2 minutes to capture something that's not going to change management for my patient. So we do educational scans, as does our colleagues in Pittsburgh, including Jennifer Marin, one of the big names in PEM POCUS. And on their scanning shifts, they found that there was no kidney on the left side. And then on the right side, so there's the no kidney left side. So it just looks kind of weird, right? So the more of these scans you do, the more you'll be like, that's weird. Do I know exactly what it is? No, because there's all kinds of weird kidneys, right? Horseshoe, crossed, fused, ectopic kidneys. So just to know, the more you scan, the more occasionally you'll say, oh, wait, not normal in some way that I'm not really confident about labeling.